Schizophrenia. In this study session, we will discuss a rare illness, schizophrenia. We will also describe the biology and effects of this illness. Finally, we will examine drug therapy for this illness. When you have studied this session, you should be able to describe the symptoms of schizophrenia, identify at least 4 types of schizophrenia, explain the biology of schizophrenia, highlight the effects of schizophrenia on the brain, and describe drug therapy for schizophrenia. What is schizophrenia? Schizophrenia is a severe mental illness that affects 1 to 2% of people worldwide. The disorder can develop as early as the age of 5, though it is very rare at such an early stage. Most men become ill between the ages of 16 and 25, whereas most women become ill between the ages of 25 and 30. Even though there are differences in the age of development between the sexes, men and women are equally at risk for schizophrenia. There is of yet no definitive answer as to what causes the disorder. It is believed to be a combination of factors including genetic makeup, prenatal viruses, and early brain damage, which causes neurotransmitter problems in the brain. Schizophrenia is a psychiatric disorder characterized by periods of psychosis. This is psychiatric because it affects the brain in a physiologic manner. The psychosis is when an individual seems to experience things that are not real or loses touch with reality. These experiences may be in combination with the real world or totally independent of the real world. Symptoms of schizophrenia. A variety of symptoms characterize schizophrenia, which include positive and negative symptoms. Positive symptoms. 1. Delusion. Delusions are false beliefs that appear obviously untrue to other people. For example, a person with schizophrenia may believe that he is the president of Nigeria when he is not. People with schizophrenia may have delusions that others, such as the police or the SSS, are plotting against them or spying on them. They may believe that aliens are controlling their thoughts, or that their own thoughts are being broadcasted to the world so that other people can hear them. People with schizophrenia may also experience hallucinations, false sensory perceptions. People with hallucinations see, hear, smell, feel, or taste things that are not really there. Auditory hallucinations, such as hearing voices when no one else is around, are especially common in schizophrenia. These hallucinations may include 2 or more voices conversing with each other, voices that continually comment on the person's life, or voices that command the person to do something. 2. Bizarre behavior. People with schizophrenia often behave bizarrely. They may talk to themselves, walk backwards, laugh suddenly without explanation, make funny faces, or masturbate in public. In rare cases, they maintain a rigid, bizarre posture for hours on end. Alternatively, they may engage in constant random or repetitive movements. 3. Disorganized thinking and speech. People with schizophrenia sometimes talk in incoherent or nonsensical ways, which suggests confusion or disorganized thinking. In conversation, they may jump from topic to topic or string together loosely associated phrases. They may combine words and phrases in meaningless ways or make up new words. In addition, they may show poverty of speech in which they talk less and more slowly than other people, fail to answer questions, or reply only briefly, or suddenly stop talking in the middle of speech. Negative symptoms. The negative symptoms include 1. Social withdrawal. Another common characteristic of schizophrenia is social withdrawal. People with schizophrenia may avoid others or act as though others do not exist. Number 2, affective flattening. Reduction in the range and intensity of emotional expression, including facial expression, voice tone, eye contact and body language. Number 3, alogia, poverty of speech. Lessening of speech fluency and productivity. Thought to reflect slowing or blocked thoughts, often manifested as short, empty replies to questions. Number 4, avolition. The reduction, difficulty or inability to initiate and persist in goal-directed behaviors, often mistaken for apparent disinterest. Examples of avolition are no longer interested in going out with friends, no longer interested in activities that the person used to show enthusiasm, no longer interested in anything, sitting in the house for hours or days doing nothing. Cognitive symptoms: disorganized thinking, slow thinking, difficulty understanding, poor concentration, poor memory, difficulty expressing thoughts, difficulty integrating thoughts, feelings and behaviors. Types of schizophrenia. Number 1, paranoid. Persons are very suspicious of others and often have grand schemes of persecution at the root of their behavior. During this phase, they may have hallucinations and frequent delusions. Hebephrenics, also known as disorganized schizophrenia, characterized by motionless, incongruous or silly behavior, intellectual deterioration, frequently beginning insidiously during adolescence, may be verbally incoherent and may have moods and emotions that are not appropriate to the situation. Hallucinations not usually present. Number 3, catatonic. Persons in extreme withdrawal, negative and isolated, may have marked psychomotor disturbances. Number 4, residual. Lacked motivation and interest in day-to-day living. Person is not usually having delusions, hallucinations or disorganized speech. Schizoaffective. There will be symptoms of schizophrenia as well as mood disorder, which include depression, bipolar and mixed mania. And the last type, undifferentiated. Conditions meeting the general diagnostic criteria for schizophrenia but not conforming to any of the previous types. Exhibits more than one of the previous types without a clear dominance of one. Biology of schizophrenia. Our thoughts, feelings and actions are all transmitted in the central nervous system as electrochemical impulses. These impulses reach the end of presynaptic neurons. Neurotransmitter chemicals are released that cross the synaptic cleft and bind to specific receptor sites into postsynaptic neurons. The binding action triggers electrical changes. These changes either inhibit or continue the conduction of that impulse. Alteration or decrease of neurotransmitters as postsynaptic receptors is associated with the many different forms of neuropathologic conditions. Major categories of neurotransmitters are cholinergic, monoamides, and neuropeptides. Each type of neurotransmitter is associated with conditions of conduction of impulses in different areas of the central nervous system. For instance, serotonin is a monoamine transmitter that innervates receptors in the pons, medulla, thalamus, and limbic system. A decrease in serotonin level is connected with clinical depression. Another example is amino acid inhibitory transmitter, a type of GABA. GABA innervates receptors in the hypothalamus, cortex, cerebrum, basal ganglia, and hippocampus. Decrease in GABA's availability is associated with anxiety disorders and schizophrenia. Family studies. The above table presents a summary of the risk for schizophrenia in various relatives of schizophrenic index cases. Quite clearly, relatives of schizophrenic parents are at increased risk, and the risk increases as the genetic relationship between proband and relative becomes closer. More recent information confirms what is shown in the table and also indicates that risk of schizophrenia is particularly high in families of females and early onset probands. The data gathered by the family method thus supports the notion that a predisposition for schizophrenia can be transmitted genetically. Yet, relatives of a schizophrenic proband share not only genes but also common experiences. The behavior of a schizophrenic parent could be very disturbing to a developing child. The influence of the environment cannot be discounted as a rival explanation for the higher morbidity risks. Twin studies. Concordance rates for MZ and DZ twins are also given in the table. Concordance for identical twins 48%, although greater than that of fraternal twins 17%, is less than 100%. The study is important if genetic transmission alone accounted for schizophrenia and one twin was schizophrenic. The other twin would also be schizophrenic because MZ twins are genetically identical. Consistent with the genetic interpretation of this data, concordance among MZ twins does increase when the proband is severely ill. Adoption studies. The study of children of schizophrenic mothers who were reared from early infancy by non-schizophrenic adoptive parents has provided more conclusive information on the role of genes in schizophrenia by eliminating the possible effects of a deviant environment. In a study carried out in Denmark under Katie's direction, the starting point for the investigation was a culling of the records of children who had been adopted at a young age. All adoptees that had later been admitted to a psychiatric facility and diagnosed as schizophrenic were selected as the index cases. For the remaining cases, the investigator chose a control group of people who had no psychiatric history and who were matched to the index group on such variables as sex and age. Both the adoptive and the biological parents and the siblings and half-siblings of the two groups were identified, and a search was made to determine who among them had a psychiatric history. As might be expected, if genetic factor figures in schizophrenia, the biological relatives of the index cases were diagnosed as schizophrenic more often than were members of the general population. The adoptive relatives were not. Effects of schizophrenia on the brain. New tests and machines enable researchers to study the structure of schizophrenic brains using magnetic resonance imagery (MRI), positron emission tomography (PET), functional magnetic resonance imaging (fMRI), and single photon emission computerized tomography (SPECT). The different lobes of affected brains were examined and compared to those of normal brains, showing several abnormalities. These abnormalities include 1. Ventricular abnormalities. The most common finding was the enlargement of the lateral ventricle, which are the fluid-filled sacs that surround the brain. Studies of patients with schizophrenia have consistently revealed the enlargement of cerebral ventricles, especially the lateral ventricles. 2. Ventricular enlargement is not related to length of illness or to duration of hospitalization. Weinberger 1980 found that the degree of ventricular enlargement predicts the patient's response to antipsychotic drugs. Patients with small enlarged ventricles show poor responses to these drugs. Test A showed that blood flow was lower in frontal regions in afflicted people when compared to non-afflicted people. The condition has been known as hypofrontality. The hypofrontality hypothesis suggests that lower activities in the frontal lobes may produce some of the negative symptoms found in schizophrenia, such as mood disorders and social withdrawal. Measures of blood cerebral flow and glucose metabolism indicate that people with schizophrenia show lower levels of frontal lobe activity than healthy controls during difficult cognitive tasks. Weinberger, 1994. Differences in frontal lobe activity can be used to distinguish between an identical twin with schizophrenia and the healthy member of the pair. One possible reason for the reduced activity may be and Lewis, 2000, found that neurons in the prefrontal cortex showed fewer dendritic spines in patients with schizophrenia. A great deal of evidence that shows that the temporal lobe structure in schizophrenic patients are smaller. Some studies have found the hippocampus and amygdala to be reduced in volume. Also, components of the limbic system, which is involved in the control of mood and emotions, and regions of the superior temporal gyrus, which is a large contributor in language function, have been notably smaller. The hastial gyrus, which contains the primary auditory cortex, and the planium temporale are diminished. The severity of symptoms, such as auditory hallucinations, have been found to be dependent upon the size of these language areas. The map in Figure 12.5 reveals the three-dimensional profile of gray matter loss in the brains of teenagers with early-onset schizophrenia, with a region of greatest loss in the temporal and frontal brain regions that control memory, hearing, motor function, and attention. Another area of the brain that has been found to be severely affected is the prefrontal cortex. The prefrontal cortex is associated with memory, which would explain the disordered thought process found in schizophrenics. Tests done on human and animals in which the prefrontal cortex has been damaged showed similar cognitive problems as those seen in schizophrenic patients. The prefrontal cortex has one of the highest concentration of nerve fibers with the neurotransmitter dopamine, and scientists have learned that the relatively new antipsychotic drug, which increases the amount of dopamine released in the prefrontal cortex, often improves cognitive symptoms. They also found that the prefrontal cortex contains a high concentration of dopamine receptors that interact with glutamate receptors to enable neurons to form memories. This means that dopamine receptors may be especially important for reducing cognitive symptoms. The psychotogenes hypothesis. Several proposals have suggested that schizophrenia develops from faulty metabolic processes in the brain that produce abnormal substances that generate psychotic behavior. Such hypothetical substances, called psychotogenes, might be similar in some way to hallucinogenic agents. The chemical structure of some manufactured hallucinogens resembles that of some neurotransmitters. Metabolic faults in particular pathways might cause the brain to convert an innocuous molecule into a behaviorally maladaptive substance capable of producing schizophrenic symptoms. The glutamate hypothesis. A disturbance in glutamate system might provide the large-scale effects that would for the wide range of positive symptoms in schizophrenia. Glutamate and dopamine systems often interact in the brain. Increasing or decreasing glutamate should result in similar behavioral outcomes. If psychotic symptoms are associated with dopamine sensitivity, They might also be related to reductions in glutamate activity. The drug PCP, phencyclidine, provides a useful model for this account process. PCP is capable of producing schizophrenia-like symptoms, including auditory hallucinations. PCP not only stimulates dopamine release but also blocks the NMDA glutamate receptor. Psychosis due to PCP use response favourable to treatment, the dopamine hypothesis. Many clinical and basic experimental findings have suggested that abnormally high levels of dopamine receptor stimulation form the basis of schizophrenia. Dopamine is a synaptic transmitter in the brain with the role of positive reinforcement. Various clues suggesting that dopamine plays a role in schizophrenia come from observations of A. Amphetamine psychosis. The similarity of amphetamine psychosis to schizophrenia is reported by the findings that amphetamine exacerbates symptoms of schizophrenia. Neurochemically, amphetamine promotes the release of catecholamines, particularly dopamine, and prolongs the action of the release transmitter by blocking reuptake. Rapid relief from amphetamine psychosis is provided by injection of the dopamine antagonist exemplar chlorpromazine. B. The effect of antipsychotic drugs. The introduction of chlorpromazine drastically reduced the population of patients in psychiatric hospitals in the United States in the early 1950s. This drug was discovered by Henry Laborit in the 1940s for muscle relaxation in surgery. The French surgeon found out that chlorpromazine not only achieves this effect but also reduces worry and pre-operative tension. Later on, Laborit collaborated with psychiatrists in trying this substance on psychiatric patients. They found remarkable antipsychotic effects. Chlorpromazine was then introduced on a large scale in psychiatric hospitals around the world with a profound impact. The chlorpromazine and other related substances, phenothiazines, act in the brain by blocking, antagonizing postsynaptic receptor sites for dopamine, specifically D2 type. This observation was subsequently extended to other antipsychotic drug classes such as butyrophenones, including haloperidol. C. Parkinson's disease. Another tale leading to the dopamine hypothesis of schizophrenia is the study of Parkinson's disease. Parkinson's disease is caused by the degeneration of nerve cells located in the brainstem in the substantia nigra. These cells contain dopamine, and administering the substance L-dopa, levodopa, a precursor for the synthesis of dopamine, increases the amount of released dopamine, which thus provides some relief of Parkinson's symptoms. Two observations of patients with Parkinson's connect this disease with schizophrenia and the dopamine hypothesis. First, some patients given L-dopa to relieve Parkinsonian symptoms become psychotic. Second, some patients with schizophrenia receiving chlorpromazine develop Parkinsonian symptoms. In fact, treatment with traditional antipsychotic drugs can result in permanent movement disorders. The hippocampus and amygdala have been found to be smaller than normal in some individuals with schizophrenia. In addition to being smaller than normal, the hippocampus shows an unusual disorganization in some cases of schizophrenia. The cells of the hippocampus are normally lined up rather neatly in rows. In the hippocampus of some patients with schizophrenia, the cells are in relative disarray. Given the importance of the hippocampus in memory and cognition, this lack of organization may account for some of the deficits in reasoning and thoughts found in schizophrenia. The disorganization of the hippocampus suggest problems in prenatal cell migration, and might reflect the role of viral infection in schizophrenia. Furthermore, patients with schizophrenia who have enlarged ventricles show a marked reduction in levels of dopamine B hydroxylase, an enzyme that catalyzes the conversion of dopamine into norepinephrine. Evidence against the dopamine hypothesis. Criticisms of the dopamine model of schizophrenia began to emerge in the 1980s. Alpert and Fredhoff, 1980, cited in Breedlove, 2002. 1. Clinical observations reveal that some patients with schizophrenia show no change when treated with drugs that affect dopamine. 2. Further experiments conducted as new methods were developed, particularly the ability to use PET scanning to examine drug action in the brain of living patients, challenged the view that the amount of dopamine blocking was correlated with clinical deficits. These studies showed that some patients had over 90% of their D2 receptor blocked by antipsychotic drugs but showed little reduction in their psychosis. This primarily occurs in patients who have had the psychosis for 10 to 30 years. At least 90 to 95 of first episode patients, however, respond to antipsychotics at low doses and does so with D2 occupancy of 60 to 70%. Number 3. Furthermore, although dopamine inhibiting medications modify dopamine levels within minutes, the associated improvement in patient symptoms is usually not visible for at least several days, suggesting that dopamine may be indirectly responsible for the illness. 4. Similarly, a new generation of antipsychotic drugs called the atypical antipsychotics were found to be just as effective as older typical antipsychotic drugs in controlling psychosis, particularly the negative symptoms, despite the fact that they have lower affinity for dopamine receptors than for various other neurotransmitter receptors. More recent work, however, has shown that atypical antipsychotic drugs such as clozapine, quetiapine bind and unbind rapidly and repeatedly to the dopamine D2 receptor. Drug therapy for schizophrenia. Although there is no cure for schizophrenia, effective treatments exist that can improve the long-term course of the illness. With many years of treatment and rehabilitation, significant numbers of people with schizophrenia experience partial or full remission of their symptoms. Treatment of schizophrenia. Treatment of schizophrenia usually involves a combination of medication, rehabilitation, and treatment of other problems the person may have. Antipsychotic drugs, also called neuroleptics, are the most frequent used medication for treatment of schizophrenia. Antipsychotic medications developed in the mid-1950s can dramatically improve the quality of life of people with schizophrenia. The drugs reduce or eliminate psychotic symptoms such as hallucination and delusions. Antipsychotic drugs help reduce symptoms in 80 to 90% of people with schizophrenia. The medications can also help prevent these symptoms from returning. Common antipsychotic drugs include risperidone, Risperdal, olanzapine, Zyprexa, clozapine, Clozaril, quetiapine, Seroquel, haloperidol, Haldol, tiroxazine, Malaril, chlorpromazine, Thorazine, flufenazine, prolixin, and trifluoperazine, stelazine. People with schizophrenia usually must take medications for the rest of their lives to control psychotic symptoms. Antipsychotic medications appear to be less effective at treating other symptoms of schizophrenia, such as social withdrawal and apathy. Side effects of antipsychotic drugs. Minor side effects include weight gain, dry mouth, blurred vision, restlessness, constipation, dizziness, and drowsiness. Other side effects are more serious and debilitating. These may include muscle spasms or cramps, tremors, and tardive dyskinesia, an irreversible condition marked by uncontrollable movement of the lips, mouth, and tongue. Newer drugs such as clozapine, olanzapine, risperidone, and quetiapine tend to produce fewer of these side effects. However, clozapine can cause a granulocytosis, a significant reduction in white blood cells necessary to fight infection. This condition can be fatal if not detected early enough. For this reason, people taking clozapine must have weekly tests to monitor their blood. Study session summary. In this study session, we examine schizophrenia, a psychiatric disorder characterized by periods of psychosis. The psychosis is when an individual seems to experience things that are not real or loses touch with reality. Positive symptoms of schizophrenia include delusions, bizarre behavior, disorganized thinking, and speech. Delusions are false beliefs that appear obviously untrue to other people. Negative symptoms include social withdrawal, affect flattening, alogia, poverty of speech, avolition, etc. Cognitive symptoms include disorganized thinking, slow thinking, difficulty understanding, poor concentration, poor memory, difficulty in expressing thoughts, difficulty integrating thoughts, feelings, and behavior. Types of schizophrenia include paranoid, habiphrenic, catatonic, residual, schizoaffective, and undifferentiated. Although there is no cure for schizophrenia, effective treatments exist that can improve the long-term course of the illness. Common antipsychotic drugs include risperidone, olanzapine, clozapine, haloperidol, thyroidazine, chlorpromazine, flufenazine, and trifluoperazine. End of study session 12. Thanks for listening.